Welcome to the Health Workforce Technical Assistance Center's webinar series. This presentation is entitled Rapid Cycle Quality Improvement, What Do HRSA Grantees Need to Know? And it was presented by Amanda Norton on August 18th, 2015.
Today's webinar is meant to discuss about rapid cycle quality improvement and what do you need to know as a HRSA grantee. So I'm going to take an opportunity today to walk through some quality improvement kind of 101, to give some examples that will resonate with some of your programs. I realize you are grantees from a variety of different programs, so it's worth acknowledging that before we get started. Our examples will touch on some of the programs and it will not touch on others, but what I can say about rapid cycle quality improvement is it really cross-cuts the healthcare and academic sector as something that is meaningful and impactful to organizations regardless of what they're trying to improve. And so I think this will really resonate regardless of which aspect of HRSA you may have a specific funding avenue in. And so I think one of the first things worth acknowledging is the key elements of quality. And this feels somewhat intuitive, but it's really kind of a three-pronged stool. And so in order to improve quality, regardless of what kind of quality you're looking to improve, you need the will, the ambition, the energy to do what it takes to change and create a new and improved system. Furthermore, you need some ideas, and so some ideas of which to base your design of this new system. And each of you coming from different areas of healthcare and academics acknowledge that there are evidence-based ideas, there are practice-based ideas, there's things in the research, but you need those ideas at which you can say, we really are confident that this is going to help us improve quality. And then the execution. Well, honestly, often we may have the will and we may have some ideas, we just don't execute them, or we may execute the wrong ideas. And so I will say this is a three-pronged stool because each of these elements are critical in order to truly improving the quality that patients and students are receiving. So you may have heard of some of these models: total quality management, continuous quality improvement, Sigma DMAIC, Lean, the model for improvement, and many, many others. And to some regards, what I would say is that these are, they're very similar models, and each of these models allow us to think about, well, what are the foundational elements at which we're going to attempt to improve the quality, again, for a specific population. In most of our cases, we're talking specifically about patient populations or student populations. But there's a real difference between quality improvement and quality assurance. Quality improvement is systems focused. It recognizes some fallibility. Teamwork is a key component, and errors are seen as opportunities for learning. In contrast, quality assurance mentalities are often look at errors as a point of punishment. We look back on solo practitioners, so we may look back on one physician, one dentist, one professor. But we always have this myth in quality assurance of perfection, so of having 100% all the time. And that yields this kind of individual focus. So we don't have a team, it's just one person trying to hold together the quality assurance efforts. Now I make this distinction because for this work we're going to talk specifically about quality improvement. Quality improvement is pretty popular right now. It's been popular for several years, but it's becoming an ongoing requirement of funding avenues of the work that you're doing, of governing boards. But sometimes we're still in a quality assurance mentality. So as much as possible, I would encourage you to kind of yield or lean towards these quality improvement ideas and away from a mentality that may have been quality assurance. One of my favorite quotes for quality improvement is, every system is perfectly designed to get the results that it gets. And I say that to start this conversation purposely. Regardless of what brought you to HRSA, what your individual program or efforts are, wherever you see that gap in your community, in the care provided, in the students that you're serving, every system is perfectly designed to get the results that it gets. And so whatever that is that you currently are experiencing, there is a system that is well orchestrated and working in unison to create those results. And so quality improvement is about putting pressure on that system, about making that system react and respond differently so that the results are in fact different. The lens of quality improvement that I'm going to talk to you specifically about today is the model for improvement. And so you heard me discuss some of those other lenses earlier. And, I think quality improvement is very much a lens. It's not asking you to do more. It is asking you to take a really specific and methodological approach to what you're currently doing. And so the lens that we're looking at is the model for improvement, and it was developed by the Associates in Process Improvement several years ago and made popular largely in the work by the Institute for Healthcare Improvement. And it's based on 3 relatively simple questions. What are we trying to accomplish? How will we know if a change is an improvement? And what changes can we make that will result in improvement? And sometimes this is called your aims, your measures, and your changes. So your aim is what you're trying to accomplish. Your measures will be how you'll know. And the changes are those ideas that you could actually try. And this balances on a PDSA, or Plan, Do, Study, Act cycle. If you're trained in other forms of quality improvement, you may have seen this called a Plan, Do, Check, Act, but the theory is very, very similar. So I'm going to work through each of these questions and provide some examples as well, and then we'll have time for questions at the end. So what are we trying to accomplish? When we think about defining what are we trying to accomplish, what this is meant to be is an opportunity for you, either within a project team, within an organizational improvement team, to set out specifically your end destination. And so each of your funding cycles have specific end dates in mind, and you are saying for yourself, by this particular date, how much are we going to accomplish? How much will things improve? For whom and by when? And how exactly will you do that? Now, you may be more familiar with SMART goals or SMART objectives. This is something that many are being asked to write these days. And so a SMART goal is exactly the same as an aim statement. And you can call it an aim statement or a SMART goal, but what matters is that it includes these elements, that it's specific and measurable, achievable, realistic, and timely. Now, within your applications, many of you were asked to put together a logic model, and so you can reflect back on the outcome of that logic model to see if it's kind of SMART or has the elements of an aim statement, or you may find this happens within some of the objectives you set forth in your work plan, and so you'd have specific objectives that should have these elements or components so we can know, were you able to accomplish this or not? Aim statements are, as I said, your destination. They are your end goal. So to use a metaphor, I live in upstate New York, and I may want to end up in California. How I get to California, there's a lot of different paths or trajectories I may go, but my aim, my destination is California. And so we encourage you when setting up aim statements to really kind of look out into the future to say, well, what would be better and improved because of all this work that I'm doing with HRSA? So an example, if we're thinking about the advanced nursing education grants, might be that by June 2016, XYZ University will ensure that 100% of clinical preceptors are prepared to facilitate a positive clinical experience for students, and so that all preceptors will undergo an annual clinical competency evaluation and score at least a 90% in these 4 areas. And so we know exactly what this university is trying to accomplish. Their focus, while there are many things within the advanced nursing education program that they could have focused on, their focus is really on building the competency of clinical preceptors. And so their aim is that the population is not so much a student base, but it really is a clinician or a preceptor base. And their hypothesis is that if our preceptors have a common core competency, that will provide our students a better experience. And so we know immediately kind of what's on the table for their work and what's off the table for their work, and we know exactly what they're trying to accomplish. Furthermore, let's think about the geriatric workforce. So we have some grantees on the line from the Geriatric Workforce Project, and in your aim statement, again, there are multiple things you could choose to work on, but you may say by June 2017, you're going to improve the primary care engagement in the early identification of Alzheimer's disease and related dementias, so that at least 90% of patients 75 years or older are assessed for ADRD at least once in a year, and 90% of those or more who are identified with ADRD have education provided to them or their primary caregiver. And again, we can look at multiple different avenues, but this particular grantee, this hypothetical grantee, has said that the bulk of their work, or this particular objective within their work, is going to hone in on how the identification of patients with ADRD and the engagement of their primary caregivers. So we know what they're trying to accomplish. As a project team, as they get working on this, they can often reflect back on their aim and say, are we getting closer to this? Have we gotten kind of sidetracked or lost on our aim statement? Have we started working on something totally different? Are we now working with students instead? Are we now working with family caregivers solely? It really allows you to say, did we have what I would call scope creep? Have we just begun to do things that were really distinctly different than we originally planned on? Or are we staying course correct, mission correct? You know, the AIM it's a simple and a powerful tool. And so there may be things, you know, knowing that we have a very diverse group on the phone now, you may work within just one small little provider office, or you may be part of a really large healthcare system. There may be an AIM that matters to you as a sole provider or sole practitioner, but that likely feeds into a larger healthcare systems AIM, or the AIM for a particular region or a multi-state region, which then feeds into the AIM that HRSA has put together in their funding request. And so while, you know, you may dissect it to get to a point where there's an AIM that really matters for your individual organization or your team who's been awarded this grant, we see that is continually feeding in and funneling up to HRSA's broader AIM. Before I move on past the AIM statement, some things that I will say really matter in creating a good statement is it needs to be relevant to your organization. The leadership and those who drive your organization or your improvement team should really care about the same. It should be something that's mission critical, that you're passionate about, and there's a real dedication to accomplishing that sense of improvement. Without that, it'll make accomplishing it very, very difficult, and it will be very easy to get scope creep. So we know that many things are being asked on each of your organizations, and sadly, this work that you'll be doing with HRSA will not be the only thing that you'll be doing. And so making sure that it's relevant and strategic will help you to accomplish that. It also is a chance for you to really form and define yourself as an improvement team, whether it's a multi-organization team or just one organization with multiple members. By identifying your AIM statement, you're kind of drawing a line in the sand to say, this is what we are setting forth to accomplish within this time frame. It keeps you focused, and it builds yourselves as a team. So let's talk a little bit about how will we know that a change is an improvement. Now, this is a question that sometimes throws people off. How will we know a change is an improvement? The truth is, actually, and I say in healthcare, but I think it's universal, we often assume things that we change are improvements, and this could be personal. You know, we could change our lifestyle, we could change our routine, we could change things that we do at work, and we almost immediately assume that we accomplished whatever it is we wanted to because of that change. And so we were sparked, we had a drive to change for some specific reason, and we automatically assume we've accomplished that. Well, the truth of quality improvement is that it asks you to take a step back and say, well, did that really work? And if we think into healthcare and into the multiple avenues or angles of healthcare, we know that there's a lot of change out there that didn't actually yield improvement. Many of us have a little bit of PTSD about being part of organizations or systems that tried out this change that wasn't an improvement. Many of us had ideas that seemed like they would be great that turned out to truly not work. And so quality improvement is asking you to just be very cautious in identifying those things that yield results and those things that don't. Because quality improvement is about improving care. It's really not about measurement. However, we have no idea if we've improved care, if patients experience our system better, if students are better prepared, unless we collect some data. But quality improvement data is distinctly different than maybe other data you've collected in the past. And so quality improvement data is for learning specifically, not judgment. Now, this is something that most of the quality improvement teams that I work with are really skeptical about in the beginning, because we have had some really bad experiences of our data being used for judgment. And in that, you know, often it's a quality assurance mentality over a quality improvement mentality, but we've all experienced when data has been used for judgment. In quality improvement, it's for learning. If your performance is 20% on something and it should be closer to 80 or 90%, it doesn't mean that you're a bad, horrible organization. It means you have more opportunity for improvement. You have a greater opportunity for improvement. We also acknowledge in quality improvement that our measures have limitations, but the limitations do not negate their value. And so in quality improvement, you're not doing research. You're not trying to prove the effectiveness of certain interventions or certain programs. They've been researched. Somebody else has done that for you. The heavy lift of that has been done. So your measures may have limitations, but they're still important because they're meant to be the voice of the system. the data collection and quality improvement should be really in tune and in sync with the reality of the work that you're doing. It shouldn't be very large assessments that aren't feasible to be done, aren't practical to be done, and that patients aren't responding to accurately or students aren't responding to accurately. You want them to be very, very sensitive to reality because they're telling you a story and giving you a point of reference. Again, we want our quality improvement data to be so sensitive to the truth of your systems so that you can know where you need to improve and tweak and where you're doing very strong. So this comes from a wonderful article, and we can make this resource available to you, but performance measurement in 3 worlds. I put this to you not because I want to go through this chart line by line, but because I think it's worth acknowledging that there is performance measurement for improvement, performance measurement for accountability, and performance measurement for research. I'm asking you to think specifically about, the column dictated for improvement right now. Now, will there be aspects of your projects that may incorporate measures from other realms? Absolutely. I think that what we're trying to talk mostly about is what might it look like if you were incorporating performance measurement for improvement into the work that you're doing with HRSA. And so the aim of this is going to be to improve care. Where in accountability, it's to compare, reassure, and spur change. And in research, you're looking to build new knowledge. And also of important note, in quality improvement, the sample size is just enough data. You're not looking to get a sample of 100% as you might be looking for in accountability. You're not looking to get all the data you can possibly collect, so this just-in-case data as you might be interested in research. Quality improvement is, they're observable tests that you're trying to get just enough data so you can make a good and smart decision on what to do next. Also really important to acknowledge is that we're looking to use our data. So we're not looking to, in quality improvement, data collection should be used as frequently as humanly possible, really. And so as often as you're able to collect it and get it into a vehicle that you're able to analyze it and use it, you should be. Where in research, we may be waiting for statisticians to run some fantastic tests on it. And so I put these 3 columns next to each other to acknowledge that each of these points of performance measurement matter. You, within your work, may have aspects of your measurement that fall within each of these categories. And if, by any chance, you have kind of overlooked the idea of improvement measurement, I think HRSA has really said that we're looking to incorporate ways to have improvement measurement as part of your work as an ongoing process. So let's talk a little bit about, so what does that mean? So the measures in quality improvement, we're asking you to look at a balanced set of measures. And so this elephant is able to balance on that ball, thankfully. But we want you to be thinking about quality improvement measures that are balanced. And so you have outcome measures, you have process measures, and then, not to be confusing, you also have balancing measures. And so outcome measures are, I often call them the so what measures. They are those kind of end goals of who will be better off because of this work. Is it students? Is it older adults? Is it dentists? Your process measures are what are the things that you may do to accomplish that improvement. And then the balancing measures is something that's somewhat unique to quality improvement, but it's really this idea of, are we robbing Peter to pay Paul? Are there unintended consequences of the work that we're doing, for better or for worse, as an impact of the work that we're doing? And so sometimes we might look at, well, if we've added new systems, have we increased waiting times for patients? Have we increased dropout rates for students? Have we increased costs? Sometimes those are common balancing measures that people will turn to as a way to say, was there just something that happened when we made these changes that we didn't expect? So if we kind of look at them a little bit closer, your process measures, your data collection may be very time limited. So you may collect your process measures just until you're confident you have a robust process. They are within your control as an organization or as a group of organizations, so it's easy to put your hands on that data. They are often linked to the ideas you're going to try, and we'll talk more about that in a little bit. But it's important to remember that process measures are a means to the ends, not the ends themselves. And so an improved process is rarely the outcome of this work. The outcome measures are patient-focused, and they really reflect how care is experienced differently for a family, for an individual patient, for a child. it sometimes really takes a while to move the marker here, and you may not be able to kind of quote-unquote put your hands on this data as easily. It may require that you get some access to state-collected data or indicators that are a little bit harder to get your hands on. But again, they're in your aim. When I said identify an aim statement that is relevant and specific and measurable, in doing so, you will have had to put at least one outcome measure in it. And if we think back to the examples I gave you, we gave you some outcome measures about how things would be experienced differently. Families would experience care differently if they were identified to be at risk for Alzheimer's disease differently. And so it really reflected back on those outcome measures. In quality improvement, how you display your data really influences how you use your data. And so some of us have some PTSD around data collection or data reporting. Some of that could be because we've been asked to collect a lot of data that is not relevant to the work we're doing, or it takes us a burdensome amount of time. Some of that could be because we've collected a lot of data and never actually seen it. So we've never seen the fruits of our labor. We're not really sure how we're performing. Others, it could be because the data exists in very large spreadsheets and we're really not using it. I cannot reflect enough on how much quality improvement is about really using and understanding your data. It's not to be shipped off to somebody else to analyze. It's yours, and you should, really be excited to use it so that you can make good and smart decisions. So if we think about the difference, in how you may use your data, and aggregate statistics, we're looking at, what happened in all of 2013 versus what happened in all of 2014. And so this particular graph happens to be percent mortality. And, we started an intervention in the very, very beginning of 2014. And so as we look at this graph, we're inclined to think that our intervention probably worked. We see a decrease in that aggregate data. When we look at this data, if we're looking at, mortality from 2014 to 2015, we find, or 2013 to 2014, we find that percent mortality in the beginning of 2013 was at about 8%. And actually something was really working to decrease that mortality. We were down to almost 2%. That's phenomenal. And then our intervention began, and we see this slowly increase. Now, does that mean that our intervention was necessarily ineffective? We're not exactly sure, actually. What this data says is we're not 100% confident that the intervention was effective. We have a lot of questions about what happened. And if I was, working with you as an improvement team, I would have wanted you to interact. And kind of right around May, I would have wanted you to jump in and say, what's going wrong? Why is our mortality rate slipping? Why are we creeping back up? And so by using the data like this, you can intervene really, really quickly before you find yourself all the way back up to 6%. The truth of the matter is that this is the exact same data. And so if we took all of 2013 and rolled it up, it would equal this bar chart, and the same thing for 2014. The devil's really in the detail in quality improvement data. When we create aggregate statistics, we miss too much information to make good and accurate decisions. It's also really deceptive, and so if we wanted to prove that our intervention worked, we may have used these bar charts to say that the intervention worked, but the truth is that it's really deceptive of what truly happened and what the system looked like. This is just one of my favorite quality improvement quotes that says you can't fatten a cow by weighing it. And I think that this has become more and more relevant in quality improvement as we are required to collect more and more data. So we're weighing, checking things very, very frequently. But we can't actually expect it to improve or get any better unless we're trying these changes to seek out that improvement. And so if we move into the final question for the model for improvement, we're looking at what changes can we make that will result in improvement. This is the place that most grantees, organizations, individuals want to spend most of their time. I would say that it is the third question in the model for improvement, and purposefully, because it is forcing you to think about what is your destination, what are these key indicators of success before you dive into the how. And so it's requiring a little bit of mental strength to allow yourself to think about those really big picture issues before you dive into the how, because the how can sometimes, you can get lost in the weeds. And we live in idea factories right now. We have incredible quantities of evidence on how to improve care. We have incredible quantities of ideas that kind of float around on the internet and social marketing sites and all over the place. So we have ideas. There's no shortage of ideas. It is the how you apply them that really matters. And so quality improvement, when you're thinking about how, what ideas can we try, is asking you to use this model of a PDSA. And so we're going to go into the real nitty-gritty details of what they are, but I will say the reason why they're important is because they're very, very fast. We are not talking about embarking on gigantic system-level change immediately. We're talking about taking one small thing and seeing how it works tomorrow. And we have a somewhat short attention span. This is, as I said earlier, this is not the only project you're being asked to do. You guys have full-time jobs, and now part of your full-time job will be this funding through HRSA, but I suspect it will not be the only thing you do. PDSAs are a very low-risk, no-harm option. We always say, whatever options, make sure you don't harm the hair of a head of a child or a patient. But by using a PDSA, we can suspect that our cost is going to be really low, the risk is very low, and allows us to try multiple ideas. No one idea wins out immediately. We can brainstorm ideas and try them all. We do that to create confidence. And in this particular model or methodology, confidence is built through experience. We learn how to adapt because through our experience, we come up with the little hang-ups, the nuances of the system that we didn't even know existed. We learn about them and we adapt. We evaluate the side effects and build momentum. So often we will see very large ideas come from our leadership or come from organizations, and they're just kind of placed upon us. We are told we now have to do our job differently. And in doing that, we build a lot of resistance. Staff of any form don't like to be told, the way you were doing your job for 10 years previously, don't do it that way anymore, do it this other way because I told you so. That doesn't typically go over really well. So PDSAs will allow you to build that momentum, decrease resistance, and make real improvement. And so often, while these ideas seem great on paper, very large system-level change ideas, they seem great in paper, they seem great in a boardroom, the practical implications of them are sometimes not as great. And I think all of us have experienced that before, where we've been, part of a really large change that just flopped, that didn't go as well as we expected. And so PDSA allows you to avoid that and make the real improvement you seek. So when you're using a PDSA cycle, there are 4 basic components: the plan, do, study, act. And so when you're putting together your plan, it is a prediction. If I do X, then Y might happen. It will feel very much like the scientific method. And so you are saying, as an organization, if I try something new, if I try assessing older adults for Alzheimer's disease and related dementias, if I try that, then I will identify a greater population and will be able to intervene. That's your prediction. After your prediction, you need a plan to carry that out. So who exactly is going to do this? Are we going to assign one nurse to just assess the next, say, 2 patients that come in? When is it going to happen? Is it going to happen next week? Is it going to happen tomorrow? And how are we going to collect this data? How will we know if the assessments have been done? How will we know what the scores were and if we identified more patients? After you complete your plan, you have to physically do that. And sadly, I've worked with more improvement teams than I want to acknowledge who create fantastic plans for ideas they're going to test, but they never carry them out. They get sidetracked and carried away with the day-to-day. And so in carrying out that plan, you are documenting and observing what goes very, very well and what happens that's completely unexpected. And so maybe you find in doing these assessments that a few patients don't show up, or that the nurse who was supposed to do them got called in to do something else and she wasn't able to, or that the family caregiver didn't want the assessment done because they were worried what the results were going to be. Because you're learning through experience, I can hypothesize a million different potential outcomes, but in doing it, you begin to really get the pressure of your system, of the reality of your work environment to know what goes well and what's unexpected. And then you take a moment to reflect back. And when I said we often assume that we get the change we expect because we made a change, that's what makes the study phase of this cycle so important and so unique, because we don't always reflect back on, from our prediction, what truly happened. What is the reality of this? we assume we got the results that we wanted to. And so you're going to compare what truly happened to that original prediction, identifying those learnings, identifying what was unexpected, and looking back and reflecting back on the data. This can be done very quickly. It can be done in huddles. It can be done in very quick, emails. It's just a chance to check in kind of qualitatively to say, how'd that go? So you might have checked in with the nurse the day that she was supposed to be doing these assessments. That afternoon before she left, you would just check in with her quickly. You check in because you're making decisions about what you're going to do differently next. And often the way you may act is divided into this adopt, adapt, abandon. But we're saying based on what your plan was, how it really went, and what you learned by doing this, what could you do differently next time? Typically, in quality improvement, you're going to spend most of your time adapting. You're going to tweak your plan. You're going to change your plan just a little bit over and over again as you put that pressure of the system on the work you're doing. And so if we think about, testing, one of our original examples was around improving the competency of clinical preceptors. And so if we're testing some ideas around that and we're, working to build the competency of clinical preceptors, we may find that there's a lot of things we need to adapt in order to do that. In the long run, we're looking to adapt to the point that we can adopt. And so what that means is we're kind of tweaking and tweaking and tweaking until we're very confident that this works, the idea is good, and that we have a process to make sure the idea happens every time it should, and then we can adopt it, which means implement it, spread it, and do it. On occasion, you'll abandon an idea. You'll try it out, and you'll find out this really doesn't work for me, or this idea works great, but we don't have the capacity to actually do it, so let's not continue to test it. But you have this flexibility through experience to say, where do we stand on this idea? Now, sometimes this can feel a little counterintuitive because I asked you in the very beginning of this presentation to think about your aim statement or your SMART aim or SMART goal. And that is a very large goal that talks about improving patients' or students' outcomes by a specific percentage. And then when we kind of whittle it down and dissect it to these smallest possible ideas that you may test, it may feel frustrating. Well, how does that relate to your aim? Well, I'm encouraging you, and in quality improvement, you start small. You are starting small so that you can ramp up these activities, so that you can build the knowledge about what works early, so that when you get to the point that you're trying to improve care for all patients, you are very, very confident you have an idea that does truly improve that care for all patients. And so it gives you this opportunity to kind of sequentially build both your knowledge and the scope of your work to the point that you, at the end, you really know what goes well. I think all of us can think back on projects where we got to the end of the project and we think to ourselves, oh, if I only would have known then what I know now. And maybe we took a very large-scale approach in the beginning. This is allowing you to kind of build that if I only knew then quickly, so that as you move through your work, you can be very, very confident that you're going to accomplish improvement. So what are some common hang-ups in quality improvement? Some of the common hang-ups are that we start far too big, and this is more common than not. We are internally probably large system thinkers. If we didn't start out as large system thinkers, our jobs have kind of put us into that position at this point, where we're thinking about how can we make things better immediately. We also are very committed to making sure whatever population we serve is getting the best, highest quality care. And so we tend to start too big because we don't want to leave anybody out in this improvement. This is a hang-up because the bigger you start, both the more potential impact you have immediately, for better or for worse, and it's often for worse, and because it takes a long time to make progress, because then we end up with the potential of decision by committee. And I think we see this a lot right now in healthcare, where we have to get everybody together to approve the idea that we're going to try. And quality improvement is about action. It's about diving right in and trying an idea. And so decision by committee is just a hang up because it really slows progress. We also implement too quickly, which means, if we tried an idea on one family or with one student and it was incredibly successful. A hang-up is then just kind of jumping to the decision that it should go to all students or all families. We still have a lot to learn. There's a lot of nuances in the sample size of 1 to the sample size of, say, 50. And so quality improvement in PDSAs lets you continue to learn that sequentially over time. Another common hang-up is making decisions without data. So if you're deciding whether or not an idea worked, whether or not you should try it on more people, and you're doing that without looking at some very specific data, you're likely to make bad decisions. So the data is going to guide you. Yes, this really did, we truly did identify more patients with Alzheimer's disease and related dementias, or no, we didn't. Without that data, you can't make a smart decision. Spreading too quickly means you may implement too quickly, which means you're trying to make sure everybody experiences this. You may also be trying to give the idea to others before you're really confident that it works. Tasking, not testing, and what I mean by this is a task is, most of our life is filled with tasks, and so a task may be giving some information to a student or putting a brochure in a waiting room. That's a task. It is just something you did. There's no question behind it. And when I said in the PDSAs, your plan has a prediction, it has kind of a hypothesis, that nuance is the difference between testing and tasking. So when you do a task, it's just you did it, yes or no. A test is, if I do X, then Y will happen. And so quality improvement wants to push you towards testing ideas, not implementing a lot of tasks. Because out of tasks, we can't really identify if the change is an improvement because there's no question there. And the final hang-up to quality improvement is talking, not doing. And this is similar to decision by committee, but quality improvement is about action. In a lot of ways, the Nike statement of just do it makes sense here. You should spend 80 to 90% of your quality improvement efforts out there testing and trying ideas, and far less in the talking about them. You're talking about your ideas when you're setting up your plan and when you're studying what worked. Besides that, you're spending the majority of your time doing, and so this can be a common hang-up because it really slows progress. It's called rapid cycle quality improvement for a reason. It should happen quickly as possible. Now, some of you are in very large academic institutions, and quickly has a different meaning than it may have in a hospital. I acknowledge that. But again, it's as quickly as humanly possible, where with students you may say, we're going to do this with the next possible student, which is different than in a hospital where you'd say, we'll do this with the next possible patient or older adult. Now, the time frame there may be different, but again, it's how quickly can we get this idea out there and really get our feet wet with it and test it out and test the waters. The model for improvement is simple yet balanced. And so in order to accomplish improved outcomes, you have to have all three questions. You can't just have changes that will lead to an improvement without some measures to know if it truly is an improvement, or without knowing truly what you're trying to accomplish, because what will happen is you'll end up all over the place. In my first example, I said I want to end up in California. Well, if you just have ideas but you don't know what you're trying to accomplish, you may end up in Florida. You may end up somewhere completely different. And you'll see this in some projects when you reflect back and you say, geez, we didn't end up doing what we set out to do because we just got really lost in the work. Or you may know what you want to try to accomplish, but you may not have any measures to know if you got there, and you may not have any specific ideas. Again, it's simple yet balanced. You need each of these three questions if you are going to truly improve outcomes. As I said earlier, there's going to be aspects of your work that are very much sensitive to quality improvement. There will be aspects of your work that are less sensitive to quality improvement. And so the charge is really to look at the components of your work plan and identify where does it make sense to utilize the model for improvement and quality improvement, where will it help me to accomplish those improved outcomes that I set forth, and will help me do that with a methodology that I'm confident works. Because as I said, this has been used across the country and in many, many other countries. It is highly, highly successful at improving outcomes regardless of the specific outcome you're seeking. And so we have a lot of confidence in this model as well. So with that, I'm going to just pause and see if we have any questions. David, have we had any questions come through the chat?
Yeah, we have a few, Amanda. And once more, thanks for showing up, and I think that was a great presentation, just to let you know. I know we started a few minutes late, and I apologize to the audience for that, but overall, I think it went really well. With that said, the first couple questions we have actually should probably be answered by HRSA staff. And so at this point in time, Candace, are you available?
I'm on.
Oh, wonderful. Well, let me go ahead and ask you a couple questions then. First question, why is HRSA requiring RCQI?
Hi, so this is Candace Chen, and I'm the Division Director of the Division of Medicine and Dentistry that runs the Primary Care Training and Enhancement, the Geriatric Workforce Enhancement Program, the Oral Health Training Programs, and I know that we have Advanced Nursing Education grantees on as well. And I will admit that the idea behind Rapid Cycle Quality Improvement actually came out of our Division of Nursing and Public Health, and so the Advanced Nursing Education was probably the first funding opportunity announcement that it got built into. And when we saw what the Division of Nursing was doing, we thought that is a great idea. And the reason that we wanted to do this, particularly for some of our programs that are 3 to 5 years, one of the things that we recognized is that we wanted to start introducing some needed flexibility in these longer-term programs. And so we recognize that when you come in proposing these great ideas, and over the course of 3 years, 5 years, we needed the ability to be flexible and to be able to evolve. And so we needed a framework by which we could do that and kind of justify changes. We recognize that a lot of times you do it already, and the way that HRSA would find out about it is sometimes in your annual report. We would find out that you ran into a challenge, and that you ended up making a change, and then as a result we might have to put a scope of work change into place because of some of those things that you realized needed to be changed about your program, things that weren't working. And what we wanted to do was we wanted to get out ahead of those things and both promote that idea of continuous quality improvement over the course of our grants, but then also be more proactive about how we partner with you and how we continue to advance and evolve over the course of the grant, so that ultimately you get to the goals that you wanted to get to, and that you're not necessarily doing things just because you proposed it 3 years ago and your funding is linked to that.
Thank you, Candace. And I have one more question for you, and then I have one for Amanda. What are the requirements for RCQI?
So we recognize that it's a new thing, and so where we're going right now is with a lot of technical assistance. As you can see, we're doing technical assistance on our own side to make sure that our project officers have a good grasp for the ideas behind rapid cycle quality improvement. We're working with our grants management folks to make sure that we have that we're all working together. And that as we go forward in the next couple of years, that we are partnering, that we are working together. The goal is not to be punitive, particularly as we're figuring out this new aspect of our grants and our grants management. And what I would say is mostly how it's going to work over the next over this project period, this grant period, for the Division of Medicine and Dentistry programs. When we have our quarterly calls with you, we will be following up on your rapid cycle quality improvement, both on what your plan looks like, what your study looks like, what you're finding, if there are any changes that you need to make as a result, and just continuing to work with you on that. So on your quarterly calls, the project officers will be following up with you on your progress in your rapid cycle quality improvement, I guess. And then in your annual reports, we'll be asking you to basically summarize your progress on your rapid cycle quality improvement over the course of the year, and it'll just continue like that for each year of your grant.
Thank you, Candace. And just a reminder to those of you in our audience, if you have questions, please use the chat panel to ask it of all panelists, and we'll do our best to answer it here. With that said, Amanda, I have a three-part question for you.
Oh, boy.
I think you can handle it. Can you provide some examples of SMART goals for A, implementing PCMH in clinical training environments, B, recruiting and training community preceptors, and C, Implementing a new leadership curriculum. Let me know if you need me to repeat any of that.
Yeah, so the first was in implementing PCMH, and so
yes.
I think the SMART objective there is actually likely the approval of your PCMH, and so it is the completion of that process and the specific or definitive date at which you seek to have that accomplished. The measures are really going to rely on, to me, kind of my initial gut reaction is this idea that your initial measures are going to be heavily process related. So what are some of the main process components that are going to have to go into getting that approval? You'll have some outcome measures that are both the completion of the process, and then you are really going to want to look at some, so why do you want PCMH? Is it because you expect that your patients will receive a better quality of care because of it? That I suspect and I really hope that that's the reason you're going for it. And so you're going to look for outcome measures that help you to define, well, what does, if we accomplish PCMH, so what? And to me, that's the critical question I often ask teams to continue to reflect back on, is this idea of so what? So what is better because we have PCMH status? I know some of you are just required to do it, but look past the requirement and really think of how am I able to provide better and improved care? And then your SMART goal is going to reflect back on those exact reasons. And so I know that you're not able to chat in, but maybe you can chat to David what you think would be better, how you would be better off if you had, how patients would be better off if you had PCMH status. And then that is going to begin to help you define what some of your SMART goal, what your SMART goal or SMART objectives are. I hope that answered your question. David, give me the second example. It was around clinical preceptors, I believe.
Yes, recruiting and training community preceptors.
Yeah, so again, the recruiting and the training, part of your AIM statement may be, well, what does it mean to recruit and train them? So how many do you want to recruit? That's very much a process objective that could be within your SMART goal. You can have some process level components that are in your AIM statement. I encourage you to really stick to the outcome, the so what, but you may begin to identify your AIM statement by saying, well, we want to recruit 30 clinical preceptors, or we want to recruit 10 clinical preceptors. So be specific with yourself about what the quantity is there. And then instead of leaning on training, I would, again, really encourage you to continue to ask that, well, so if we have more clinical preceptors and let's say they're all adequately trained, again, what will be better off because of that? Do we think our students will be more prepared? I think if you think back to one of the first examples, if you were on the webinar and able to hear that audio, we really talked about building clinical preceptor competency. You could also build something in there around, well, how will that make the student perceptive or experience different? Will you see improved graduation rates? Will you see better performance during their clinical times? And so your AIM statement would hone in on, well, what are the measures of success there? It's not just about finding and training preceptors. It's about that bigger issue of, well, why do we need more, and what are we going to, how will students' lives be better because we have more? David, what was the last area?
Implementing a new leadership curriculum.
Okay. So, I just really wish I could speak to you, but implementing a new leadership curriculum, the two things I would say is that's potentially just a task. And so, as I said, there will be things about the work that you do that will be sensitive to rapid cycle quality improvement, and there will be things that won't be. And so just adding a new leadership curriculum may not be sensitive to quality improvement. It may be if, again, you have greater goals or objectives for that. So if you're, I'm not sure if your leadership curriculum is with students, I'm just going to kind of assume that it is, but if you implement this leadership curriculum, how would you know that students were better prepared to be successful leaders? And so, again, I think the leadership curriculum is a means to the ends. It's not the ends in itself. And so it's asking yourself that, again, that next level of questions of how will students be better off if they complete this course? How will they be at a better advantage than their colleagues who didn't get this course? How would I see that either immediately in their academic performance, or maybe you would see that more long-term in their job placement? or the positions that they're taking post-graduation would be my initial thoughts. So I think the common thread that came to me on each of these 3 questions is that it really is just thinking about another step farther, continuing to ask yourself the more outcome-based avenues of these really specific objectives that you've set forth, because I think you've identified some really fantastic strategies, and just keep asking yourself, well, why do I think I need to do this strategy? You're doing all this hard work because you want something to be better. You want students to be better prepared. You want your patients to receive better care because you have PCMH status. And sometimes, you know, PCMH status might also help you with billing issues. It might help you with insurance issues. I think you can be honest and forthcoming about that, but always get back to what does it mean to the population you serve. And if you can't get to that, I think you need to dig just a little farther.
Thank you, Amanda. I believe we have time for one more question. The New York Times ran a very interesting story in their Sunday edition about Amazon. Amazon uses data-driven methods for all their operations. Are there safeguards to implementing data-driven decision-making that do not lead to the problems described by the New York Times?
Well, I didn't read the article, so in full disclosure, I didn't read the article. I can say that data-driven decisions are critical to improving all healthcare, and that really learning how to accurately and frequently use data will safeguard you from making inaccurate decisions. And so to some regard, and this is, again, not the opinion of HRSA, my own somewhat skepticism, I think in the past we have made some rather bad decisions because we haven't used our data to its fullest potential, or because we've aggregated it or rolled it up to a point that we were misinterpreting in it. And so what I would say is that using frequent time-sensitive data will give you the tools that you need to really be sensitive and intuitive to the needs of your system and to make those accurate decisions. What I think is also a safeguard to that is being really thoughtful about the balancing measures. And so I talked quickly about a balancing measure. It is often overlooked and neglected by improvement teams. And so thinking for yourself, well, what would be the flip side of this coin, this whatever endeavor it is? Maybe it's your leadership track, maybe it's clinical preceptors. Thinking about what is the flip side of this effort and having that balancing measure will help you to safeguard against potentially just either robbing Peter to pay Paul or not using your data accurately. There's a lot of fantastic courses out there on how to use quality improvement data. I'm happy to share those resources with you. I think it's a skill to be developed within an organization. You may not have those skills quite yet. So I think building that as just capacity building would really help you safeguard.
Thank you, Amanda, and thank you for attending our webinar. Just a reminder to the audience. Yes?
There's a question in the chat. Can I answer it real quick?
By all means.
This is Candace Chen again from Division of Medicine and Dentistry, and the question in the chat box is, how would HRSA like us to report on the RCQI? Are we required to use specific tools for documentation? And what I would say is right now we have no specific tools for the documentation of the RCQI component. Like I said, when we do our quarterly calls, which some of our programs have done it differently. We're working to standardize a little bit more, but it'll essentially be a call directly with your project officer. You will basically summarize and discuss your RCQI and any findings that you have since the last time you talked, and any changes that you might make, and our project officers will be capturing that in the quarterly calls. And then in the annual report, there's a format already for the annual report, but we are going to give you a little bit of guidance. Again, it's largely aimed at a summary of essentially the conversations you were already having in your quarterly calls, and any changes that resulted as a result of your RCQI processes. And what we're planning on doing is before you start doing your annual reports, we'll do a technical assistance call to talk more about what should go into those reports. And that's it. Thank you, David. Sorry.
No, that's quite all right, Candace. Thank you for providing that information. And once more, thank you everyone for attending. We will be posting the slides of this presentation to our website shortly. Our website once more is located at healthworkforceta.org, go to resources, and under the resource tab, there is a rapid cycle quality improvement section. So go to that, and within the next couple of weeks, we will be posting a video of this event. So once this event closes, you will be directed to a short evaluation survey, so please provide us with your feedback. We'd love to hear what you'd like to learn in the future about RCQI. Thank you. Have a good afternoon.